order. I would appreciate it if board members are able to come on camera, and I will take a roll call. And I also want to let you know that our chair, Dawn Mountner, she will be joining us. She has an urgent meeting this morning, and once that meeting ends, she will be here, and I will turn over chair duties to her. Chicky Flowers also has a conflict this morning, and she will be here in 30 minutes. So I am going to start with Greg Klauser. Greg, are you here?
Good morning.
Great, thank you, Greg. Andy, are you here?
I'm present.
Great, thanks, Andy. Kimberly?
Good morning.
Good morning. Sean Parkman?
Morning.
Hi, Sean. Emily Wong, are you here?
Yes, I'm here. Good morning,
All right.
everyone.
Good morning. And is Rob Nose with us today?
Just got here, yes.
Just got here. Okay, great. Thanks, Representative Nose. All right, so I believe that's everyone here for the moment. And then both Chicky and Dawn should be joining us. Do I have a motion? Has anyone looked over the minutes and is ready to make a motion so we can approve the minutes from our November in-person meeting? Did I hear you, Greg, or did I hear something? Maybe I didn't do it.
This is Kimberly. I make a motion that we accept the minutes as presented for the November 18th, 2025 meeting.
Thank you, Kimberly. Do I have a second?
This is Andy. I will second.
Go ahead.
Okay, I think we have two people seconding it, both Greg and Andy. I think I'm just having a little trouble hearing you this morning, Greg. So I've got Kimberly who put the motion forward, Greg and Andy both happy to give a second. So Sean, how do you vote?
Approve.
Okay, and Emily, how do you vote?
Approve.
Okay, so we have a quorum approving our minutes. All right, thanks everyone. And so before we move into our first presentation, I do want to acknowledge that we have had a change with who is administering the Providence Health benefits. Collective Health, Providence made a decision to contract with Collective Health to administer the benefits. And I think it's important for us to understand as a board, this has been an incredibly rocky transition. This has been a challenge to see. I know we had some issues with Evacor that took a while for Providence to iron out. And then we had the move to the alternative care in the fall, the changes that were not impacting our providers and our PEBB members, but the communications led people to believe that was the case. And so that was tough for folks. And then at the beginning of this year, this is something that is impacting all of Providence members. And it's something that I have certainly seen a number of concerns raised by our members around. Those of you who have fully read the packets can see that we have some public comment around the transition. And I just want to say that, you know, this is a really challenging time for folks across the board. There have been so many disruptions in government service, and our members really rely on having stable health care, and the transition, such a rocky transition, has meant many people have tried to get care at the beginning of the year, and their providers thought they did not have coverage, and there was a lot of work done to make sure that people could get coverage when this should have been a seamless transition, and it has not been. So I just want to make those comments before I hand it over to Ali to talk about it a little bit. I also want to acknowledge that for folks who have ongoing health conditions, it really is unacceptable, and is also unacceptable for the folks who needed emergency care at the beginning of the year and were denied care because it looked like they didn't have health care coverage. So I just think it's important for us to understand that and to acknowledge the overtime work that our PEB staff have been doing through the weekends to respond to phone calls and help troubleshoot these issues. So Ali, if you would like to just describe the scope of the issues that your staff have been dealing with, I think it's important for the board to hear.
Yeah, happy to,
thank you,
Siobhan.
and good morning and Happy New Year to everyone. Yeah, I mean, I think Siobhan, you gave a really good description and background of kind of where what we've been experiencing. These first 2 weeks have obviously been very challenging coming out of the new year. We weren't quite prepared for all the issues that we've been experiencing, and what I'd like to do is provide the board with some examples of these challenges that have kind of plagued our Providence plant since January 1st, and what we as staff continue to work on with PHP and with Collective Health to resolve the issues that our members are experiencing, and hopefully to proactively get in front of potential future problems. So again, you have some public comment in your packets submitted from members that articulate very clear frustration on many levels, and I think the public comment that was submitted is one of 3 emails from this member that really, I think, since January 2nd has run into pretty much every issue or problem that I'll talk about here in a minute. But I'd like to say that the Providence Health Plans and Collective Health have been very responsive in meeting with us and strategizing every day. We spend about an hour with them to identify and track and resolve issues as they occur. They've been super responsive. Our member services team has been amazing and has worked many extra hours in these first 2 weeks to really get on top of these issues and to resolve issues as they come up. I've had 2 calls this morning from people that showed up at their doctor's office and were told that they didn't have coverage, and that's alarming on many levels, but those are getting to be much fewer. I think providers are finally starting to get the communications, and I'll let our Providence team and Collective Health address that. But some of the major issues that we've experienced since January 1st have been provider confusion and network uncertainty, and not really getting into technical issues on data feeds, but some providers are just confused on who Collective Health is and thinking it's a new insurance company that they're not contracted with. And I know that Providence has sent out a lot of communications to clear that up, but then some providers, including pharmacies, are unclear on how to verify eligibility and telling members that they don't have coverage, which again is very alarming. Member confusion about who Collective Health is, confusion related to moving from My Providence to My Collective for online plan information. I know we've sent out some communications. I know Providence Collective Health is sending out another communication today. Undelivered ID cards for some members. Some members has been about 500 that we're working through various issues, address issues, but that's a high number and has caused a lot of issues. Our customer service call center, just for our member services team, has really been extremely busy, much more than normal. But I know on the Collective Health side that long hold times and abandoned calls has been a real issue, and we've had some really upset members that have kind of given up. These are coming down, but are still much too high for what we expect. Then some issues related to prior authorizations not transferring over to Collective Health, and glitches related to coordination of benefits. And again, we're working through to make sure that we address and identify any gaps on prior auths and coordination of benefits. And these are real issues that our members are experiencing, and again, some are rightfully quite upset. We feel like we're getting on top of the issues and not as reactive as the first 2 weeks, but again, I think Providence and Collective Health has dug in with our staff and to resolve the issues as quickly as possible. So with that, Siobhan, if you'd like to introduce our guests for today.
Yes, so we have 3 guests. We have Scott Burton from Providence, Dawn Antonucci from Providence, and Ali Diab from Collective Health. And Ali Diab, I apologize if you thought I was handing it over to you initially, since I was not paying attention that we have 2 Alis here today. So I'm gonna hand it over to the 3 of you.
Thank you. This is Don Antonucci. I'm the CEO for Providence Health Plan. And first of all, I just want to acknowledge that this is not the way we wanted to start with this transition. And so what we wanted to do today is, first of all, I just want to say Providence Health Plan, just like Providence, we have one North Star for us, and that's to know, care for, and ease the way of our members, our patients, our providers. And this is where we have some work to do on this. And as you've talked about, we've got our teams working night and day to get this into a really good position and spot. So what I wanted to do is, first of all, because PEBB is such a long-standing, important client to us, so we've served you for 18 years, have had that privilege, is break down for you kind of what's happened, where we're going, and the why behind the transition. And really, it falls into a few buckets. One is awareness that you've just kind of touched on and talked about. This was, I think, surprising to folks in terms of both from a member standpoint, but also from a provider standpoint. And we'll talk about some of the communications and efforts that we had put in place around that. 2, we'll talk about issue resolution in terms of what is actually happening, what's outstanding at this point. And then we'll also make sure that you have a good understanding of the direction we're heading in and the why behind it. So with that, I want to momentarily turn it over to Scott Burton, our market president for Providence Health Plan. He's going to walk through some of that. We've got Ali Diab here, who's the CEO of Collective Health, who I've known for some time as well. And you'll learn a little bit more about Collective Health. And then we've also got Cash Spencer waiting by, who's a phenomenal senior director of our ASO business here at Providence Health Plan. So Scott, I'm going to turn it over to you.
Yeah, thank you, Don. And if the PEBB staff will go back one slide, please, I'll hit the communications momentarily. But I appreciate the opportunity to address this PEBB board this morning to provide a status update on the Providence Health Plan powered by Collective Health 2026 benefits plan implementation. In my time with you today, I'd really like to focus on 3 key items. First, as Ali mentioned, there's been quite a bit of discussion the past 2 weeks regarding a lack of awareness by PEBB members and local providers of this new partnership. So I'd like to outline that this has been a significant contributing factor to both a challenged member experience and confusion in the care delivery process. So I'd like to ensure that you have visibility to the efforts that began last spring and those that continue now to ensure members and providers are appropriately informed. Next, I'd like to provide you with a summary of the primary resolution issues that are being worked jointly by the Providence Health Plan and Collective Health staff, along with PEBB staff. More work certainly remains, but we are making progress daily. And as Don said, and as Ali will reinforce shortly, issue resolution remains the #1 priority of both of our organizations. But let me begin by briefly regrounding this board on the information provided to you on April 15th of last year by Mercer and by PHP staff when we introduced you to this new partnership at your in-person board meeting in Salem. We conveyed to you at that time that an overwhelming majority of our self-funded customers, including PEBB, had expressed several consistent needs that Providence Health Plan alone simply could not administer without significant investment of capital and time. These needs included highly personalized advocacy services, a robust digital member engagement platform, and enhanced claims and population health capabilities to slow rising health costs in alignment with the state's cost growth target. Developing these capabilities would have taken Providence Health Plan years and hundreds of millions of dollars to build internally. And so, after a nationwide search, Collective Health emerged as the partner who could deliver those capabilities at scale. In fact, Collective began developing those capabilities and delivering them to employers nationwide more than a decade ago. The goal was, and remains today, to provide members with a more modern, more integrated, and more responsive experience while working to create greater affordability in a historic period of healthcare. And so as we move to our first slide, following that April board meeting, as we began the operational readiness work, we also developed and executed a comprehensive and consistent communication campaign targeting both members and providers. Let me begin with PEBB members. Working in partnership with PEBB staff, we began communicating to the membership about this change last summer, providing email, mailed awareness pieces, and other communications touchpoints. In July, September, October, November, and December, members were mailed, emailed, and invited to attend webinars to ensure that this new partnership would not be a surprise on January 1st. Not only would members be receiving new medical ID cards, but PEBB would also be issuing them new P numbers, similar to P numbers utilized by PEBB members on other medical plans and other carriers. These numbers would be accessed through PEBB Enroll, and collectively, these were material changes that members would need to understand prior to January 1st. Despite at least 19 different touch points communicated across 6 months, January 1st brought a surge of emails to PEBB staff, calls to Providence Health Plan customer service, and calls to Collective Health customer service. Members stated they did not know this change was happening, as you heard Ali mention earlier this morning. They also didn't know what their P number was or even what a P number was. This surge of calls and digital outreach, more than 4.5 times the number of customer calls experienced in 25, overwhelmed both the Providence Health Plan and the Collective Health call centers, resulting in long wait times, member confusion, and member anger. This was further compounded by approximately 800 PEBB members not receiving welcome packets in the mail that included their ID cards. In some cases, we know that those packages were thrown away, with members unaware that they would be receiving new member ID cards as part of this implementation. Others did not receive their welcome packets due to an issue with their physical addresses not appearing in a format sufficient for USPS to deliver. As we move to the next slide, unfortunately, the experience on the provider side was similar. Providence Health Plan began communicating to providers about this new partnership in August of last year. Letters, emails, alerts in our digital provider portal, and human communications between our provider relations staff and providers' payer relations counterparts all transpired from August through December. Yet as members began to access care following January 1st, providers similarly flooded PHP's various provider relations channels, expressing they did not know about this change and did not know how to verify member coverage was active. The surge of calls had a similar impact, with provider front office staff experiencing far longer than normal wait times. Some providers, as a result, canceled or considered canceling member appointments, citing lack of eligibility verification. And as Ali mentioned this morning, that issue continues. This was further compounded and continues to be by inconsistent eligibility results found by providers accessing a platform called Availity, or reflected in file feeds ingested by some provider systems that they use to verify member eligibility. On our next slide, with that as the backdrop, today we're focused on 4 key areas of resolution. First, ID cards. We've identified the root cause of that physical address issue I mentioned earlier. As of today, we're down to approximately 187 members whose addresses remain undeliverable. And so we continue to investigate the cause and work with the United States Postal Service to get those ID cards and welcome packets in members' hands. Given that members now have access to a true digital ID card as a result of our partnership with Collective Health, we've also provided members with custom registration links that pre-populate that often unknown P number, so members can access their digital ID card or request additional mailed ID cards. And on a case-by-case basis, where members are missing a card for a dependent or have other ID card issues, our team is working through normal customer service channels, and staff from our rapid response team are working to get new cards in members' hands as soon as possible. In the area of communications, We continue to communicate with PEB members, providers, and PEB staff regularly, ongoing, daily, and by the hour. We're holding daily escalation and remediations with meetings with PEB staff and aligning the issues and metrics we see on our end with the experience of PEB members. We've held webinars and question sessions to provide facts and updates to PEB members, and we continue to mail and provide web and other digital updates to further facilitate awareness, education, and member support. In the area of member advocacy and service, call volume and digital outreach to both Providence Health Plan and Collective Health member advocates remain high, but it is steadying. We're down from approximately a 4.5 times volume we saw right after January 1st, and we're now approaching a 3-to-1 volume, with benefits checks, medication issues, ID cards, and digital registration comprising the top 4 topics daily. We've trained and added additional member advocates to support this enhanced volume, and we continue to leverage emails and digital efforts to encourage registration on the My Collective platform. The higher we can drive this registration, the more directly members will have access to the resources they need. We've also added a callback feature, so members don't need to wait in queue to speak to someone. If members' hold times reaches 3 minutes, a prompt will give them the option to be called back without losing their place in line. And finally, for providers, we continue to work with the technology companies that operate the Availity platform and support those digital file feeds to providers to ensure accuracy and eligibility checks. We've added new provider phone line prompts to allow them to look up member IDs by phone. And by the middle of next week, we expect to have an additional feature available to providers that will allow them to look up member eligibility without using the P number. So before I turn our time to Ali Diab to share his thoughts as our operating partner, I want to reinforce that we remain committed to following through on these resolution efforts, and we feel confident that as this implementation stabilizes, this partnership will lead to a better experience for PEB members in the future. Ali, let me turn the time now to you for a few brief remarks before we open the time for board questions.
Thank you, Scott. Thank you, Siobhan and Ali, for the intro and preamble. I'm Ali Diab. I'm one of the founders and CEO of Collective Health. We're a 13-year-old company based in San Francisco. I founded the company after having my care denied by our insurance carrier at the time while I worked at Google. So these issues are near and dear to my heart. And I think the only things that I can say in response to the fact pattern in front of us is, number one, I'm sorry. I don't know what else to say. It's a very deeply embarrassing and frustrating position for me personally to be in, given the premise of our organization and the mission of our organization. And just to echo what Scott said, my team is working along with Scott and Don's teams around the clock to resolve these issues in partnership with you all. And we do appreciate the dialogue with Ali and others on your team daily to give us the feedback that we need in order to execute that priority well. I'd say we're not out of the woods yet. I think we probably have still a few weeks of turbulence ahead of us. It will get better week over week, but I just want to set expectations that it's not going to be something that gets resolved immediately overnight. It's a significant transition. You guys have been, and the providers that you work with and that your people see have been on a certain modality for almost 2 decades. And the change management alone is hard for people, even with the best of intentions and the communication that we have done over the last 6 months. And then equally, there have been some idiosyncratic things with the transition that I think I would say our team probably wasn't as prepared for as they should have been. And we own that. It's not something that I'm proud to say, but that's just the reality. So the change to the new P number, for example, has been problematic for us. And there have been some idiosyncratic coordination of benefit and prior authorization requirements, I think, as Ali alluded to, that we didn't, I think, fully plumb the depths of before the transition, but we are now on top of. Just so you understand the marching orders I've given my team on my end, given that eligibility and access to care is the top priority. I've told the team to really focus on those issues above all, especially for people with the most acute needs. I realize there's not a significant, but it's still important, number of people who have very significant, very acute care needs. And so our care navigators and member advocates are focusing on unblocking those people's access to care by getting on the phone themselves with providers or doing whatever they need to do in order to make sure that they're verified that they're eligible and have access to care. And then as Scott alluded to, there are a number of other issues that we are knocking down progressively, including just sort of, I would say, day-to-day blocking and tackling, like delivering ID cards, et cetera. And we are working with the U.S. Postal Service and others who are actually helpful as well, trying to understand why those kinds of packets are being returned. So again, I don't know what else to say other than I'm very sorry for the situation that we are in and for as rocky a transition as you have gone through. Certainly not what I would have liked to have been my first interaction with you all to explain myself. But I do want to assure you that we are, and we do have a capable team. We are working to knock these things down. And as I look at the trend overall, week over week, it does give me reason to believe that we will get out of this. But it will take, I think, another, I would say probably 2 or 3 weeks of a little bit of choppiness to do that. I'm happy to answer any and all questions. And I have read all of the feedback that your members have provided, and it's pretty hard to read.
Thank you. And thank you, Ali Diab, for recognizing that this has been a really difficult transition. And I just want to note Kimberly's note in the chat around your honesty here. I just want to see if board members have questions or comments to make.
This is Kimberly. I'll just make just one real quick comment. I did wind up going in for a blood draw, like literally the 3rd of January, which who would have known that that was like a bad time to go in. And Saniam Hospital, what they did, because they, with the P, threw their system off because it wasn't the numbers anymore. It started with the P, which we've all had a P on our numbers as long as I know. Anyway, but they, as a team, Saniam Hospital, they had a plan in place. They set aside, they still took care of the patients, and they made phone calls saying, another one just came in, going to set it aside, treat her as good to go. And they took care of it internally. So I didn't notice any disruption, but they definitely scrambled. Like I said, I was there the 3rd of January, and, but they took care of me. So, and I wrote to Ali, our Ali, and said, I was able to figure it out, Collective Health. So I didn't have any issues, but I do know I've been hearing from our people. So, but thank you.
Thanks, Kimberly. Any other questions or comments? All right. Well, I know we'll continue to hear updates. And Ali, go ahead. Ali Hassoun.
Yeah, thanks, Siobhan. I just wanted to mention, we'll come back with another update at the next board meeting. As we get into billing and claims processing, there might be some updates there. We're trying to get out ahead of that, make sure that goes smoothly. And again, appreciate Providence and Collective Health coming here today to address these issues with the board.
And Sean, go ahead.
Yeah, I appreciate the direct accountability and taking ownership. Just for on our side, just because we have such tight budget constraints, I think at some point we'll need to have, and Ali Hassoun, I think this might be a question for you. If we have accumulated additional costs, over time, this sort of thing on our side, due to needing to scramble, it might be good for us to just understand what the size of that is, and if current budgets can allow and absorb that sort of thing. And then the other thing, just as far as following through, and I'm hearing this is happening, so but just for the sake of the board's oversight, understanding what the physical health interruptions may have been for some of those that, I mean, it's one thing if it's just like kind of like routine care and we had to, someone had to delay for like a month or something. because of confusion. It's like, well, that's inconvenient and pretty annoying, but then there are some of our members who are much more fragile than that health-wise. And so I think we'll need to understand, if what the consequences were on some of those folks, like if has anyone been in the lurch, kind of like left behind medically, even temporarily, like are there consequences of that? Did they take a step back on health, that sort of thing? So just as we're moving forward, that would be good to kind of focus on just getting our arms around that kind of thing so that we can understand the scope of that.
Thanks, Sean. Andy, go ahead.
Yeah, I think it just reiterated what Sean said. If we had members that have, that medical issues and those were compounded by not being able to get care, that whatever it takes to get them back up should make sure that it's covered, and that they get those services to, again, make up for having gotten worse or whatnot.
Right. Thank you, Andy. So I know there's going to be lots of follow-up on this topic. Our chair has joined us, and I know our next agenda item is to discuss the utilization dashboard, and Emery Chen from our Mercer team is here to do that, and I am going to hand it over to Dawn to manage from here.
Thank you, Siobhan. Good morning, everyone. Thanks for covering. And Emery, over to you.
Thank you, Chair. So yes, so I'm here to present the utilization review. This actually, I think we can move on. It's a semi-annual report that I present that talks about what the claims have been and some of the changes and the impacts of the care that's being delivered to the members and the cost impacts to PEB. This as a semi-annual report, we do have like time periods which are either on the fiscal year or on the calendar year. Because we are using incurred claims. This is going to be data through June of 2025 for the current time period. And it's if you take a look at there at the top, the current time period is the 12 months ending in June 2025. Depending on the slide that we show, there are different time periods, 1 year prior, which is through June of 24, or sometimes even 2 year prior. So that's through June of 2023. You can see the plans that we provide. Self-insured is statewide plan, Province Choice, and MOTA, and then we have the Kaiser fully insured plans. There's a couple caveats down below, and I think maybe add another one regarding rebates, but depending on what slides we show, some slides do include some integrated care fees for Kaiser, which aren't reported as claims, but they are part of the overall cost. They're essentially for non-claim services, care management from Kaiser. And also on rebates, depending on the slides, some pharmacy slides we do show include rebates. Some don't because we wouldn't be able to accurately split out the rebates by the specific drugs, but we will hopefully note those slides and provide some context around it. But as mentioned, just we are looking on a fiscal year basis here, so the data is through June of 2025. Okay, moving on to the actual claims information. Okay, so we show 3 different slides for total just kind of gross costs. In this case, this one's the self-insured slides. We do have the fully insured, the Kaiser plans on the next slide, and then the combined total for PEB. We have the total cost there at the top in aggregate, and you can see some of those changes are a little bit bigger in terms of overall costs. On the far right, that is the change from current to prior. We do have a 12% increase in, so 11.9% increase in total cost. for the self-insured plans. As you can see, for medical, it's a little bit lower, 11.7, but pharmacy is a little bit higher. The pharmacy does include impact rebates, so that does offset some of the costs, but overall the costs are increasing low double digits. On a per employee basis, it's a better number because your enrollment has been increasing by about 4%, 4.4 if you're talking about employees. For members, it's actually 3.6. So on a per employee per year basis, and it's been increasing 7.2% in the self-insured cost. You can compare that to the prior time period, couple columns over right in the middle. That increase was 7.8%. So pretty consistently for the self-insured costs, you've been increasing in about that 7-8% threshold. So that's pretty close to what we've been seeing, Mercer has been seeing, and I guess other clients, other companies, healthcare has been trending at about 7 to 8%. So PEB is not immune to that. Unfortunately, it is above the 3.4% limitation, which PEB is limited to. So yes, the costs are increasing a little bit more than what PEB is limited to. Rob, you had a question or comment?
You just answered it.
Okay. Yeah, we'll have more detail on the breakout of the costs per employee, and cost per member and the reasons behind it. But it is trending. It's not like PEB has seen like huge growth. You're not really an outlier. Despite the size, you have been essentially a price taker in terms of some of the healthcare impacts, and this is what Mercer has been seeing. And Andrew will actually, I think, have some more information than that in the primer, but you are not unusual in this situation. Okay, next slide. So on a fully insured basis, it's actually a little bit better story. So overall, the costs have moderated a bit to about 6% increase in aggregate. And if you take a look in that middle section on a per employee per month per year basis, it's a little bit less than the 3.4%, a little less than 3% at 2.9. And that's pretty consistent between the medical and prescription drugs. So for Kaiser, the costs are, it's more moderate. You can see the prior change has been bigger in like low to getting close to mid double digits. So over the 2-year time period, we are talking about about 13% cost increase over 2 years, which is a little bit better than what the self-insured plans have been seeing, but still is pretty close to what what trend has been across the marketplace. Okay, next slide. Thank you. So in aggregate, so combining this self-insured and fully insured, the costs are increasing about 10.6% in aggregate. When we take a look at that per employee per year in the middle section, that's really I think the one we focus on because that's what the budget is, essentially comparison against the limitation. That's about 6.3%. A little bit, that's above the 3.4% limitation, but it's kind of a similar story, a little bit, bit of a moderation compared to where it was last year, but still, above the 3.4%, but in line with, I think, again, trend. So when we start, I think next month, we're going to talk about the RBC and where the costs are in terms of the fund surplus, the surplus, reserve fund. It's probably going to be kind of similar story to prior periods, which unfortunately, isn't great because PEB is spending more than the 3.4%, and so there needs to be things done, hopefully, that will help bring down the costs to get closer to that 3.4%. Any questions or comments before we move on to a little bit more of the granular detail? So the next section breaks down the trend and into the various components. This is on a per member basis versus a per employee basis. So the annual increase is going to be a little bit higher because you have the member growth is a little bit smaller than employee growth. So that does make the total annual increase there at the top 7.7% versus more of a 6.5%. Um, if you take a look at what's causing it, there are a couple different bigger reasons for it. It's not unit cost, it's actually utilization and member health risk. So a couple things there. Utilization is increasing in certain, I think pharmacy continues to increase. There's still usage of office visits, mental health services, and ER visits. While it's not a huge increase, they are getting a little bit more costly. And increasing ER visits is not the best way of utilizing care. So those are some of the drivers there. In terms of the member health risk, 4.6%, I think, that is higher than we'd like to typically see. I think as members age, it's about 2 to 3% per year. In terms of health risk, the increases are typically there. But this may be a little bit in terms of also the members and how they're changing, because your employees are increasing and the members aren't as much. So that could be driving up some of it. Some of the members, it could be an overall age increase that's causing a little bit of this erosion or increase in health risk. But it is a component of the overall cost and managing that risk, through care management, through advocacy, and what the plans can do and providers can do to keep them healthier, especially like preventive care and some of the things that CIA's doing on cardiovascular risk. Hopefully those maybe longer term things, but can help impact this member health risk and bring it down and keep your members healthier and maybe not have the cost increase as much from year to year. Okay, next slide. Oh, go ahead, Sean.
Well, we've had this conversation over the years, but it sounds like maybe worthwhile for us to think about it this year. I know we have a lot on our plate. So question is, member health risk that's a big blanket number that hides lots of different things. And so, one question is, to what degree is this increase related to a small number of serious, acute, like very expensive individuals, which frankly we have some things we can do, but I suspect the interventions there are more limited because they have the condition that they have, versus a kind of broader base, sort of large chunk of our members that are increasing risk kind of spread out over, so it's kind of like the diabetes versus hemophilia sort of, what I mean? That kind of split. So I wonder at some point if we could get a little bit of a breakdown on that, just like what is going on. Is it what we're used to? Well, actually, we've had times where it's been both. It's been a different thing in a different year. We've had a couple of like very serious high spending folks that kind of like skewed us. And then we've had other situations where it's like, yeah, or, diabetes is up and it's like very broad and so on. So I wonder if some point, not right now, we can just kind of put it on the menu for kind of digging in and see where we're at.
Yeah, we definitely can look into that and look at stratification of the member health risk again to see where it is increasing the most. It is, I do think in a situation like right now where the economy is not maybe as robust as it could be, and hiring isn't happening, right? You aren't getting that many. You do have older base of employees, and there aren't as many younger employees coming in, and that helps moderate this health risk issue. So I'm not surprised to see a little bit higher health risk increase because essentially you're going forward with the population you have, right? But we can definitely look and see where the losses or where the erosion is happening in terms of the health, where the risk scores are going up a bit more. We have some information that some conditions on patients, and that's going to be on slide 21. So we can talk about a little bit more. There are a few areas where it definitely has been a little bit more impactful there. And they're not necessarily like the super high cost areas. It's more like kind of behavioral health is one, but there's also like back disorders and obesity, just kind of like sort of aging issues, just general health cost issues increasing there as well.
That'd be good. Yeah, it would be good to understand like that analysis about like new members versus established members, and is that what's going on, and versus high impact members and so on. Yeah, it would be good to just take a look.
Yeah. Okay. Okay. Next slide, please. So this breaks out the trend components that we showed before based on the different types of service categories. On the far left is inpatient admits. Really, there hasn't been, that's not a driver. It's really everything else. So the outpatient, physician, and RX, those prescription drugs, those costs have been increasing more. On the inpatient, we'll show later on, it's really the types of admits actually have been a little bit lower. I think there's been one or two higher cost admits that might show up in the next utilization report, but it's not a driver in this utilization report. In terms of the outpatient physician, it's kind of a consistent, well, you have the risk scores at the 4.6, but utilization's kind of increasing as well. So the outpatient visits, outpatient services, physician visits, those are increasing. The pharmacy, again, the utilization is increasing as well. And there's certain drugs. I think Sarah Drake might be on, hopefully, to talk about some of those drugs in the next few slides. But it's a little bit of a consistent, I think, I don't know if someone used the word erosion, but increasing of costs and services. And the mix of services are getting a little bit more expensive as well. So that's just kind of impacting the overall cost. It's nothing that's like, well, except for I think a few pharmacy issues. It's just a continual increase, I guess, across the board for the most part in this case. That's impacting the trend. Representative, yes. You have a question?
Hey, Emery, I sometimes make an off-the-cuff remark in committee where I go, everybody wants to be paid. And to me, that's what this sort of shows. Like, we've had a good run for a while, and then post-pandemic, everybody just wants to be paid better. Now, maybe their costs have gone up too, but like, I just feel like that's a thing that we're also experiencing.
Yeah, that definitely is. I mean, I think that's been a common theme brought up by the health plans. It's negotiations, right? The difficulty of that. And then everything that involves the labor market, just permeates through healthcare as well. And yeah, I don't know. Inflation's kind of been relatively, I mean, I guess it's at 3%, but for healthcare, it's always been a bit higher. New technologies is probably one of the areas where healthcare has been gets impacted more than anywhere else, right? New services, new mix of drugs. You combine two drugs and call it a new drug and add a patent to it, and it just costs a lot more.
Yeah, I agree with that too.
So, and
it's unlike the dental benefit where improvements come along episodically. I feel like in the healthcare space, they come upon They come along constantly. And then
Yes.
we're constantly having to try to change our benefit to accommodate a new thing.
There's
Okay,
a
I'll go back
lot
on
of
mute.
money in health. Yeah. Sorry. There's a lot of money in healthcare, right? And there's,
It's because it's not a coordinated system. So everybody takes their opportunity to grab their little chunk of what's out there.
yeah, there's I don't know,
If only there
a lot
was
of
a way
profit.
like every other country does this. Never mind.
I'm not sure this is the time to get to a policy discussion. We don't have enough time. Sean.
Could you give us a little flavor of what all other might cover?
Yeah, so I'm gonna probably mess this up because I've had this question in the past and I don't always remember all of it. You know what? I might have, I don't want to misspeak
That's
on
fine. That's
exactly
fine. Just
everything.
yeah,
I'll have to
later.
get
It's
back
all
to
right.
you.
It's all right.
Yeah.
Just follow up later. I'm just kind of going through my mind. It's like, gosh, if it's not in person, inpatient, and it's not outpatient, it's not physical. It's like it's not
Yeah.
prescription. What is it?
We
So
we
okay,
lumped,
yeah,
yeah.
just follow up after. It's no big deal.
Yeah,
Sorry.
we lumped some stuff together in there which doesn't fall as neatly into these buckets. So I'll have to take a look. I can't, yeah, sorry, I can't remember off the top of my head. I really should, but I just don't. Sorry. Okay. Moving on to the next slide. Looking at each plan, where are the increases happening or where are the changes happening? Because Kaiser HMO, you can see there's actually a decrease in the biggest change. It's a decrease there down at the bottom. But for Providence Choice and statewide, specialty drugs continue to be kind of the biggest driver there. Take a look at some of the bullets down. Increased use of Skyrizi. Sarah, I believe you're on. I don't know if you want to add some comments about some of the drug costs that are increasing here.
Yeah, absolutely. And we've got a couple of additional slides too. We can show you some of the specific drugs. Not surprising across just in general, the fastest growing prescription drugs are the GLP-1 medications, Mounjaro and Ozempic. They're used for type 2 diabetes. And we've talked a lot about the GLP-1s. But like Emery mentioned, we're also seeing continued growth of these anti-inflammatory biologics. They're used for conditions like Crohn's disease, rheumatoid arthritis, psoriatic arthritis, psoriasis. Skyrizi is the number one there. It is made by the same manufacturer as Humira. It's kind of in the same class, although it works a little differently. But that's not the only one. We're also seeing growth in drugs like Cosentyx, Tremfya, and Rinvoq. Those are all anti-inflammatory biologics. And then Dupixent, which is used both for asthma and then it's being marketed for atopic dermatitis, which is another name for eczema. So it's a lot of these skin conditions, biologic drugs, very expensive. The list price on them ranges between like $50,000 a year to $85,000 a year. There are rebates available, but even with the rebates, there's still at least half of that. So that is one of the big drivers of spend along with the GLP-1s. The other thing I would add is on the outpatient side, and we'll see this in the other slides as well, growth around cancer treatment, particularly Keytruda, which it's referred to as a checkpoint inhibitor, but it's being used for more and more types of cancer. There's good results for it, but it is very expensive.
Thank you. Yeah, and so go ahead.
Oh, I just had a quick question. I was curious if, I see the fastest growing prescription trends are for the GLP-1s. Are we seeing them being prescribed to prevent type 2 diabetes as well, or only for type 2?
So under the PEBB plan, it's only coverage of the FDA labeled indications. There's not FDA approval for pre-diabetes. There's only FDA approval for type 2 diabetes. The CDC recommends typically diet and metformin for some people with pre-diabetes. Because as of today, there's not an indication for that. So to answer your question, no, they're not they're not being approved for pre-diabetes.
Okay, thanks.
Yeah, I think the growth is due to both just potential increase in diagnosis of people that have type 2 diabetes. And then also there's been a big change in the treatment guidelines over the last few years where we're seeing GLP-1 recommended earlier in treatment than it was in the past.
Okay, that's helpful. Thanks. I know we continue to have members concerned about our coverage of GLP-1s, and we saw that in the public comment too.
It made me think about a few years ago, just before the pandemic, we were doing a project, the board, in our plans around pre-diabetes, you know. And when we looked at that, there was like a group of people, like a cluster of population that was right on the precipice of type 2 diabetes. And so I wonder if now, and we were worried about that because if they move over, it's a whole different class of costs. And so I wonder if what's happening is we're not reaping that, like that's exactly what happened, is that they've, that group, a significant portion of that group that we were looking at a few years ago, 5 years ago, pre-diabetics have now moved into diabetes. And so we're kind of harvesting that, the consequences of that now. I don't know. So that might also be worth looking at when we, in all of our extra time that we have this year, of just like, what is our pre-diabetes versus diabetes situation? Like, I suspect that didn't just stop, right? There's like a queuing up of like pre-diabetes and then into diabetes. And it's like, what does that look like now?
Emery, did we have, I thought I saw some data around the prevalence of diabetes, or at least what we had in the data wasn't really showing an increase.
Yes.
Is that right?
Yeah, so slide 21, the diabetics, in terms of the patients, hasn't been increasing. They've actually kind of been pretty flat or dropping. Moda's the only one that had a bit of an increase. But that has been an increase over the last couple years, right? I think as people wanted to get, check into GLP-1s, they got treated more often. The number of patients did go up. So we're kind of reached maybe a threshold, a plateau of diabetic patients. But it has been an increase in the past, but not in this latest report.
Okay. So yeah, so that's just something for the future that would be good to look at. And then, so what might be happening then, what I'm hearing is that maybe the cost of managing diabetes, a diabetic patient, is going up. And we're probably on the top of a wave that's maybe cresting of diabetes in our population. So, I mean, it would also just begs the question, the costs of treatments going up, are the positive outcomes for diabetes actually going up as well? In other words, are they having better lives because of the increased costs, or is it just increasing costs? That would be as far, as like, is it better managed? In other words, is there better life satisfaction, etc.? I mean, these are all good to know. I would want to know, if we're spending 20% more on managing diabetes, is diabetes 20% better managed? So anyway, I don't know what metrics we could throw at that, but I would be interested in the discussion at some point later.
One of the things that we're doing through the CIAO work group is looking at utilization across the carriers of different medication regimens for diabetes, and then looking at how the hemoglobin A1C, which it's just one metric and it's not perfect, but it's a measure of how well blood sugar is controlled in type 2 diabetes, and looking at what we're seeing in terms of movement towards better hemoglobin A1C across different medication groups. And so that's an ongoing data project we're working on, refining, just to better understand where there might be opportunities for improved prescribing to make sure more people are moving towards improving their hemoglobin A1C. Because thought is better A1C long term, better control means, you know, fewer problems with diabetes, better health.
Yeah, that's great. I look forward to that. Yeah, look, fewer blindness, less amputations, you know, and so on.
All that
you know,
stuff,
so,
right?
Yeah.
Yep.
Great.
If I may, Sean, I think it's a good point to bring up. Are we improving the diabetes and the long-term health as well as spending and utilization associated with care if we're managing the diabetes better upfront? I think that we are still early enough in the phases of the GLP-1s that we still don't know what their long-term impacts are on health or utilization. But we do know that they are considerably more expensive than any of the other ways that we manage diabetes, which means that we're spending a lot upfront, and there is no guarantee of return on investment in that way for these drugs in this phase at this price point. I don't think that we certainly don't have data yet, but that would be enormously optimistic. Emery, back to you.
Thank you. Actually, the next couple slides I think are on pharmacy, so I think I'll turn it to Sarah to kind of go through these.
Sure. So this slide just provides a breakdown of the different types of pharmacy spend and what's happening in those different channels. So there's the non-specialty drug spend. Those are the typical prescriptions that are picked up at a retail pharmacy. That you can see is 9.3% year over year. There's the specialty medications dispensed through the PBM specialty pharmacy. That's that big growth area, about 11.5%. And then there's the medical professional and medical outpatient facility. And so it's important to keep in mind not all prescription drugs are processed through the PBM or the pharmacy benefit. Some are billed on medical claims through outpatient and professional. And you can see the breakdown there. It's, you know, over 25%, or about 25% is the medical specialty. Let's go to the next slide.
That was a good slide. I don't think I realized that.
Yeah, and it is growing. I mean, if you think about medications like what's used for cancer, that's all being billed on the medical side.
That's right. It's all live stuff and infused and
right.
Yeah.
And Sarah,
and go ahead.
The cell and gene therapies are included with pharmacy. Am I correct? Yeah, we'll get to those, no doubt.
Yep.
Yeah.
You'll see some of those show up on the medical specialty slide, which is after this one. So this slide shows these are your top drugs and what's driving trend in the pharmacy benefit. So you can see there, number one is Mounjaro, that's a GLP-1, and then you'll also see Ozempic there, that's up considerably year over year. Some of the other drugs we talked about, there's Humira, which is near the top, and that's trending down. That's because there's biosimilars available for Humira. So a lot of people are migrating from Humira to biosimilar, and there's some savings there. That's great news. However, at the same point, you're seeing that growth that I talked about with those other drugs like Skyrizi, Dupixent, Tremfya, Rinvoq. Those are all kind of in that same category. Representative, I see your hand is up.
So the other day I was putting around, probably ironing, and listening to an NPR show about compounding of Ozempic style medications and how these compounders, frankly, were getting around the cost. It was fascinating. This is probably a rabbit hole we don't have time to go down, but like, is that a thing that PEBB could do?
Is it a thing? Yes. Is it a regulatory gray area? Also, yes.
Yeah.
Right. There's some safety and efficacy concerns, like the compounders are getting the raw ingredient.
They talked about that in the show.
Yeah, they're not FDA approved. Some of them have been tested. There's concerns about potency, purity, all of that. So
okay, never mind.
Yep.
Going back
it's
on
out there. Yep. Some of the other things I just wanted to highlight here, that Comirnaty, that one is number 7. That's one of the COVID vaccines. That's the name for the Pfizer COVID vaccine. So in the past, those were free from the federal government. There's a big increase there because now those fall to PEB in terms of the cost. And then you're also seeing growth for things towards the bottom. You know, in addition to more Ozempic, there's that Dexcom sensor. That's continuous glucose monitoring. We're seeing more of that for people with diabetes too. Sean, I see
Sean?
your hand is up.
Yeah, I was just gonna say something that I said at our last in-person meeting, and it's just sort of a broad comment, right? Since 1980, we've added something like 1,500 to 1,700 new drugs to market. And during the same period of time, life expectancy in the United States went down and life satisfaction went down. And so it's just sort of I don't know what to do about that. It's just sort of an existential question, you know? It's like, what are we doing? It's like, it's not, this is not the silver bullet, but we're throwing so many resources at it. So I'm just, no, you know, we don't have to really comment about it. It's just, I don't know what to do about it or what to do about that. I'm just mentioning it again because it's just like a big question for me.
That's a fair question. You know, I would say that there have been categories of drugs that have increased life expectancy pretty significantly. Far fewer people are dying from heart attacks than were in the 80s, thanks to things like high blood pressure medicine, statins for cholesterol. Those are all good things. Those drugs are cheap. The conversation gets more challenging, I think, with some of the drugs you're seeing here. So your point's taken. Just other things I wanted to call out real quick, like 13 and 14, those are also COVID vaccines. And then Paxlovid, I believe, is on here too. Yes, number 11, that's the COVID treatment. So those are all new costs to the plan because in the past they were covered by the federal government 100%. Any other questions or comments on this one before we look at those medical pharmacy drugs? Okay, let's go to the next slide then. So I think the question earlier, does the gene therapy or the cellular therapy show up here? And the answer is yes. So you can see that number 1, that's Zolgensma. So you had a one-time Zolgensma last year. And so that's why the trend is lower this year. If you look at most of these other drugs, they fall into one of two categories. There's a couple exceptions, but they're either for rare ongoing conditions or they're for cancer. And so that number 2, the Nexviazyme, that's for Pompe disease. It's a rare genetic condition. Nexviazyme actually treats the same condition as Lumizyme, which is on number 4. So I didn't look at the data as close as Emory did, but I suspect that might be the same patient that maybe switched from Lumizyme to Nexviazyme because that's a newer drug that has some improved outcomes after people plateau. So that might be what's going on there. But Keytruda, that's a cancer medication. Yervoy, cancer. Etcetera's cancer. Bonvetti, that was somebody who probably had a bleed with von Willebrand's disease last year. Didn't have one this year. That was a one-time. But most of this other stuff, Yescarta, that is for cancer. Rylaze, that is for another enzyme replacement for a rare condition. So by and large, that's the challenge of these medical specialty drugs. It's for really rare conditions where there's not a lot of other options to treat them, or it's newer cancer treatment that are targeted, more effective than the older cancer treatment, but they come at a really high cost.
Yeah, and it's a lot of these drugs are being administered in facilities, and facilities are subject to Senate Bill 1067. The one thing about that is, 1067 limits it to 200%, but a lot of these, a lot of their contracting is being paid at close to the 200% level. And so that's 200% Medicare for these drugs, which is what, pretty much at sale price, Sarah, or close to it?
Medicare, it's sales price plus 6%. So Medicare pays a slight markup, but yeah, 200% when you're talking a $50,000 drug, adds to the cost pretty significantly.
Yeah, and so that's one area where I think it, like unintended consequence, right, of Senate Bill 1067. It did save money, but potentially offers, without contracting, does offer, like tight contracting does potentially make the costs higher for some of these things than they should be as a result. But it's something that we're looking into, and especially for the IWG, and we're doing some reporting on that. But it's it's an issue that we're looking at.
And I think there's probably an issue too, Emery, that just over time, more and more cancer medications are being given at outpatient cancer centers that are part of the larger facilities. I think in the past, more might have been done in individual provider offices. There's been more consolidation, a lot more use of the outpatient hospital facilities, and that's increased some costs too.
Well, thank you, Sarah. I don't know if there's anything else you want to add, but okay. So moving on to the next section, taking a look at the risk score. So this is, if you remember, the 4.6% increase. It does translate, if we round down around to two figures, to about 5% there on the right for PEB from the prior time period to the current time period. The risk scores aren't evenly distributed in terms of the increase. If you take a look, MODA, they're essentially in the middle, had the biggest increase. They went from 1.04 to 1.13, so their average member is 13% more costly than PEB, or actually, I guess, compared to PEB in 24 is 1.05, so that's about 8% higher, and that is a higher risk than what statewide plan has in this case. So the Province Choice and statewide, they increased about 4% from year to year. For Kaiser, the Kaiser HMO actually was about 2% increase. So MODA is essentially bearing the brunt of the cost increases in terms, or risk score increases here. So they are getting the higher risk members. The next slide is a slide that I think we show and talk about quite a bit. It's the normalized cost by plan. So if you take a look at the overall cost for providing care to a member, which includes admin and rebates and ICM fees, that it can tell you something, but not unless you also take a look at the risk of the member. And, with MODA having that higher risk member, while their costs may end up, their costs are actually not, I don't know, like a little bit for 600, 6 something. When you normalize it, they're actually end up being, they stay kind of like the lowest overall normalized cost for PEB compared to the other plans. So essentially, that would be efficiency of the care delivery, and they're at about $604 per member. You take a look at the Province Choice and statewide, they're closer to $650, and then Kaiser's above $700. So I think this is something that we've taken a look at over time. Historically, it really hasn't changed that much, honestly. This always seems to be kind of the lowest normalized cost comparatively. Okay, next slide. So moving on to some of these top conditions, this takes a look at episodes. Episodes are usually done on a calendar year basis, and so with the data, you might see it's a little bit different from this year to last year, because I think some of the claims haven't kind of flown through, where it's lower, and it really, theoretically, it shouldn't be lower, but just kind of focus on the ranking. So this is where it has the most impact to PEB. So the top one, again, is diabetes. I think we've gone through that in terms of the cost and how care is delivered, but that's just the most costly clinical conditions here. Second one, mental health services. That one moved above pregnancies, or deliveries. Last year, pregnancy was number 2, and mental health was number 3. Now it's flipped, especially with some of the, I guess, not as much costly deliveries that are happening. Sorry. And then some of the others, I think 5 with joint disorders, that's up from number 8, and we can take a look at actually on the next slide. Let's move on to the next slide, honestly. Clinical conditions by plan. So musculoskeletal, back down in the second from the bottom. Lower back disorder, in terms of number of patients, that has been increasing double digits for most of the plans. So MODA, province, and statewide, more patients there per thousand, 10 to 13% increases. If you look at the section up above, obesity, for MODA, province, and statewide, that also is increasing pretty close and kind of in line with that lower back disorder. So there are definitely some more issues, more costs associated there. Taking a look at some of the other areas in red, let's just go to the top. Mental health. We've talked about this, I don't know, for many, many years, I think since COVID or even pre-COVID, but in terms of the patient, it continues to increase. Anxiety continues to increase all across the board. Depression's increasing again all across the board with some pretty big increases for MODA and provinces at 8%. Kaiser deductibles about almost 20%. And then the second section down below, this is an area where CL is focusing on cardiovascular. And you can see there is a good reason for that. Chronic heart failure and coronary artery disease, CAD, those number of patients is increasing quite a bit. And, if, in terms of the higher cost, if they do get into that, chronic heart failure or artery disease, that's, you start getting some really bigger dollars being impact per patient in this case. Any questions before we move on? Comments? Okay. Just a time check. Chair, I think I have until 11. Is that correct? Okay.
Yes, I think that's
All right.
right.
So, okay, so we'll move on kind of quickly through these next few, or actually the rest of the section. So preventive screening rates. The number of visits, preventive visits between employees and spouses is below our book of business. Just want to reiterate, Kaiser reports preventive visits differently. Basically, a lot of them aren't listed as preventive visits, so it doesn't show up here. So in terms of the actual visits, you're probably closer to typical for employees. Spouses maybe a bit below in this case. In terms of screening, breast cancer screenings higher, as well as colon cancer there on the far right. Some of the drivers in terms of outpatient costs, lab costs, Cologuard's actually kind of the usage has gone up quite a bit. So that's maybe contributing to that colon cancer screening rates there on the right. In terms of cervical and cholesterol, a bit below book of business in this case. What you see here is actually kind of typical. I don't think it really has changed much over the past few years in terms of whether you're above or below for these different services. Next slide. Next section. Okay. So executive summary on some of the different types of categories here. So inpatient, that's not really a driver. Unit utilization costs actually slightly decreasing. Outpatient office visits, it's kind of moderate again, not huge increases, but they are happening, and behavioral health in some cases is a driver. Emergency room, this is one area where the costs per visit's increasing, and part of it's due to the acuity level. There's level 5, the highest acuity level. That number, the percentage of visits associated as level 5 went up by quite a bit. And so that's driving some of the costs in this case. So maybe those visits needed to happen, but they are a bit of a cost driver in this case. The other ones, again, kind of more of a moderate lab and radiology increases, and we'll have a little bit more detail there. And then prescription drugs, I think we talked about that, or Sarah talked about it quite a bit, GLP-1s and Skyrizi. Moving on to the next slide, which should be inpatient admits. The admits kind of actually slight decrease, as I mentioned. It kind of depends on which plan you're looking at. Most of them are decreases, with MODA having a bit of an increase, but the cost per admit's actually dropping quite a bit for MODA. Deliveries and substance abuse, which are some of the lower cost admits, were some of the bigger increases, and as a result. The other admit costs are increasing, except for Kaiser HMO. So, on average, it's pretty good. Not that big of a driver, at least for this time period for PEBB. The next slide talks about office visits, I believe. So small increases across the board from 0.4 to 3.4%. So on average, it's 2.1. In terms of the number of visits, allowed cost, the biggest increases are for Kaiser. So Kaiser's allowed per cost is increasing quite a bit more, 5% for HMO and 12% for deductible. Just typical established office visits are increasing 7% on average or so for Kaiser. Next slide, please. Emergency room. So talked a little bit about this in terms of the cost per visit. For statewide and MODA, about 5%, 4%, respectively, in terms of the increase in number of visits. And that bottom number, it's something that we've kind of looked at in the past. It's like the severity level and the distribution of the emergency rooms. I mean, you don't want the level 1s or level 2s, because that's probably not necessarily should have gone to the emergency room. But the level 5 is definitely increasing quite a bit, 17.7% of visits to 20%. So that's almost like 2.3 points. And so it's like number of, on a percentage basis, we are talking 15 to about 20% increase in those types of visits. So those are costs that are like $3,000 to $3,000 per visit, driver of why the allowed amount per ER visits increasing. So it is a bit of a driver, at least for PEBB. Next slide. Lab services, I think moderate increases, although I think combined it does get you to about 8%, 8 to 9% overall cost increases. And note below, utilization of Cologuard increased 300% for MODA. They are $500 per service. So they're not cheap services, and that's part of the driver of the cost amount. But it is cheaper than going in outpatient and getting a colonoscopy. Next slide, please. Radiology, similar story to lab. Mammography screenings impacting Kaiser deductible in terms of the number of visits, cost per service. It's increasing a bit for MODA and statewide. Cancer treatments were drivers. I think talking about cancer, in terms of the outpatient pharmacy for MODA being a driver, it's seeing a relative increase, at least in terms of radiology services as well for MODA. Okay, next slide. Prescription drugs, I think, again, we went through this in a bit of detail. The scripts are going up by about 4%. So in terms of utilization, that's at 4%, but the allowed cost is going up 10%. We've talked quite a bit about the reasons, cost drivers there. If we take a look at the next slide. This kind of breaks out the allowed per brand, and so the brand GLP-1s, right, and Paxlovid, as mentioned before, those are major drivers here. Allowed for generics increasing a little bit, but not nearly as much. Utilization's increasing again on generic utilization. It's about almost 87% of overall drugs. In terms of the brand drugs, again, the GLP-1s and the rheumatoid arthritis, the Skyrizi, and those others are kind of really causing, GLP-1s here, because Skyrizi is I think on the next slide, but GLP-1s is definitely driving some of that brand cost here. Next slide, please. And then here is the breakout of the specialty, which does include the facility pharmacy, medical pharmacy in here. The cost, the utilization's increasing 7%. Allowed cost is actually just 1.5, but still that's about 10%, 9 to 10% increase overall. Utilization's increasing most for Kaiser, deductible, and WODA. The overall impact of specialty drugs, it's actually just 0.3 points on the overall allowed costs. In the past, we've seen it more of an impact, but it's still a little bit of a cost driver here. Okay, we are at 11, but I'll go through the last couple slides. Strategic recommendations. The mental health again continues to be one. With CL with the standards for wait times, and we'll see. Hopefully that will help. How that helps, and integration with EAP and some other wellness and other programs. Hopefully that helps out, as well as some of the virtual mental health services, because that's still increasing quite a bit. The second one, cardiovascular, I mentioned before. CIAL's working on that. So bringing that as part of the hopefully improvements for 2027, aligning with what CIAL's doing there, as well as workplace wellness, lifestyle and prevention, trying to hopefully bring down some, make PEB healthier again. Next slide. Are a couple final ones. Diabetes, I mean, that's, GLP-1s continues to increase. And Sean, I guess, really, and what CIAL's doing to make sure the most efficacious drugs, most efficacious treatments for diabetes is actually happening. And then I think we actually talked quite a bit about that specialty pharmacy, in terms of medical as well as PBM, just some of those impacts. Hopefully steering to lower cost settings, lower cost providers, as well as cost-effective options for, biologics, especially like biosimilars, increasing the use of those as well. So apologies for kind of going through those final slides a little bit quick. I did run a little bit over, but with that, I will turn it back to you, Chair, unless there are any final questions.
Thanks, Emery. We spent a lot of time in there asking more questions and wanting to really understand some of the drivers of these costs, and that would support more of a conversation about strategies to improve them over time. But it's not clear to me that we have the time now to spend a lot of time, but I do want to open it up. Board members, do you have questions for Emery or the team about this and specifically about the recommendations? All right, hearing none, let's go ahead and I'll express my gratitude. Thank you for this presentation. As always, the understanding of what's behind, and the willingness to partner over time, as we will continue to have some more questions about this and the implications for where we are here, what we're seeing for the next phase, including the RFP. Let's go ahead and take this break and return at 11:10 to begin with the primer on the renewal. Thanks, everybody. Welcome back, everybody. Board members, if you could please come on camera or give me some other signal that you're back when you're back, that would be great. Hi, Andrea, Ragnos, Siobhan, Sean. Hello. Hey, Emily. All right. That looks like we've got a quorum. Hey, Greg. Thank you. Let's go ahead and get started. Andrew, I think you might be taking point on this next section of the agenda with the primer on the renewal.
Yes, I am. Thank you very much.
Yeah.
So nice to see everybody today. I think we've got 30 minutes for this portion of today's board meeting, which I think is going to be plenty of time. And so, yeah, here we are, renewal primer. The intent here is really to start talking about the 2027 plan year renewals, and make sure that board members, you all know what's to come in these next few months as we go through rounds 1 through 3 of the renewal, and work with you to make sure that you're adequately informed for any potential program changes that you might want to look at for 2027, that sort of thing. And so we've split up this content you can see here on our agenda slide into a couple of sections. We'll spend just a couple of minutes talking about current state. And so we'll go through a quick recap of which carriers and which benefits are renewing 1/1/27. We'll go through a quick recap of last year's decisions that the board approved for the 2026 plan year. And we'll talk a little bit about healthcare affordability as well in that section. We'll then shift gears and start talking about 2027. This renewal cycle is going to be a little bit different from the past few years because of the medical and pharmacy RFP. And so I'll mention that at a couple of points throughout these slides in these next 30 minutes so that you can understand some of the nuance related to that. Our intent is really to have these two efforts sort of run in parallel. And so when we're talking about the renewal, we're typically talking about dental, vision, life and disability, your supplemental coverages. And when we need to talk about the RFP, for the most part, those will be separate presentations. These obviously are very related topics, and so there's going to be a little bit of overlap. But in breaking it out, and one of the advantages of breaking it out in that way is that it carves out a little bit more time for the board to focus on dental and vision, life and disability, some of these coverages that, in prior years, maybe there hasn't been as much space to really focus in on them really deeply. Because medical and pharmacy just sort of is such a big topic. It's a lion's share of your projected costs, that sort of thing. And so there will be some unique opportunities, which will be nice as we go through these next few monthly meetings focusing on the renewals. Okay, with that said, I think we can jump to the next slide, please, Rose. Actually, 2 slides. Thank you. Here's an overview of the PEBB benefits and carriers in these sort of vertical categories broken out by benefit type. And so, as I mentioned, we're not going to spend a lot of time talking about medical and pharmacy in these renewal meetings. It'll be more dental, vision, life and disability, and some of your supplemental programs. And so we have thrown a little pink star on a couple of your carriers. The first is Unum, which provides LTC to PEBB members. This one, it doesn't really renew per se. There isn't an annual contract that renews. There's an ongoing agreement. There are, as I think board members, as I think you're aware, there is a rate increase that'll be coming effective 6/1/26. Unum is also will not be accepting new enrollments as of February of this year. And so there's a lot of communication efforts that are going out from staff as well as from Unum directly to members so that they're aware of some of these changes that are going to be coming down the pike in the next 5 or so months. The other carrier that we have starred here is Canopy. Canopy provides EAP services for PEBB members. Canopy is in the midst of a 2-year contract agreement, a rate guarantee. And so this is not one that we will need to renew as of 1/1/27. It will next renew on July 1st of 27. Pause and see if there's any questions or comments. I'm not seeing any, so I think if we want to, Rose, if you wouldn't mind just jumping to the next slide. I'm going through this current state section a little bit quickly so that we can get into the 2027 focus section. This is just an overview of the decisions that the board voted on and approved in May of 2025. And so these are the final approved actions. This isn't necessarily a running summary of all the activities that occurred in the renewal last year. For example, there were some rate concessions that occurred in round 2 and round 3. Those are not captured here. This is merely what the board approved in May to achieve, a 3.4% cost increase and be in compliance with that mandate. And so we've combined a couple of these by carrier. You can see, you all are familiar with the big ones here: Garner, mail order pharmacy program, removing the HEM program. And so again, this is just sort of a quick reminder in case you haven't been thinking about the renewals because this was many months ago. Just sort of a quick refresh on final actions that the board approved, including use of reserve dollars to again ensure 3.4% was hit, but also to maintain low-cost plan status for those plans that needed to be lowered relative to the statewide plan. Last year was a big year for renewals, as I'm sure you all remember. There were a lot of different sort of balls in the air that the board was navigating. Providence and Collective Health integration was one. We heard from those teams earlier today. Garner was a really big implementation, so it was a removal of HEM was another big choice. So it was a big year. And so again, this is just a reminder to sort of set the stage as we start to look forward to 27. So I think we can jump to the next slide, which would be the last in this first section, where we talk about current state and kind of the operating environment at a high level. And so this is an interesting slide, I think. It shows 4 data metrics over the course of about 10 years. So I'll just get you oriented and then make a couple comments on, well, what does this mean for PEB? And so in blue, the blue line, that is annual change in total health benefit cost per employee. That population are employees enrolled in employer-sponsored commercial health plans. The purple line here is overall inflation. That's not healthcare inflation. That's just general inflation. In green, we're showing workers' earnings over time over the last 10 years. And then in pink is the PEB total health benefit cost per employee increase by year. And so a couple of points to make on this slide. One really speaks to affordability generally in this country for those who are enrolled in employer-provided coverage. And I'm not talking about PEB employees at this point. So if you compare that blue line, which is change in total health benefit cost per employee, to workers' earnings, you can see from 23 through current, the cost of benefits is increasing faster than workers' earnings are. And so what that means is that there's more pressure every year for employees to be able to afford their medical coverage. And so compare that dynamic to PEB, the pink line, which is coming in lower. And you can see that this really speaks to the success of PEB in terms of managing that annual increase and ensuring that affordability is there for PEB members. And as you all know, that's such an important part of the sort of value prop for an employee working in Oregon, a public employee. Rich benefits that are affordable. And so, PEB has a lot of advantages that your standard sort of small or mid-market or even large employer doesn't really have. And so PEB has these advantages, and those have definitely been used, to the benefit of PEB members when it comes to keeping costs manageable and keeping these plans affordable. I'll pause. There's a lot to take in. There's a lot of data here. We can probably start shaving off some of the older years. Maybe we'll do that next time around. But I see Rep. Nost, you've got your hand up.
Yeah, if you would just recap for me what you think some of those key advantages are besides the size of our population.
The size is a big one, but there's others. SB 1067 is huge. So those legislative advantages.
Okay.
Oregon's sort of medical home structure and PEB's plans, which really steer folks to those medical homes. That's another thing that's bringing costs down. Your ability to use reserves is another big one, frankly. Your typical private employer doesn't have sort of a bank to dip into, and obviously that comes with pros and cons. Like that's not an easy decision necessarily. Other things related to your size around, better leverage with regards to negotiations or negotiating innovative performance guarantees that a smaller employer is just not going to be able to drive with their carrier partners. All those little things add up. Having these dedicated committees, which we're going to talk about a couple that support the renewal process, that really works to PEB's advantage. So strategies on evidence and outcomes work groups,
That's good.
CIO, IWG.
You're
So-
staffing me for a meeting I'm having with private sector employers today at 4:30 about the cost of health insurance.
Okay. All right, good. Good timing then. Yeah, that's great.
Andrew, I have a question.
Yeah.
How does this compare to other employers who are covering health insurance for their folks' book of business, like the comparisons on prior slides?
Yeah, so I think there's a couple of things. So, a lot of the sort of market forces that are at play in healthcare in Oregon and in this country, like PEB is subject to those too, right? Like we saw those in Emory's utilization dashboard. A lot of that stuff, like PEB is also subjected to. Where PEB has an advantage is on some of those things that I was just sort of rattling off for Rep Nos. But when you think about, so a couple of things. So that blue line there, which shows that's the increase in costs after an employer or plan sponsor has made plan design changes. Similar to PEB's pink line is also, those are post decisions, right? Those are post implementing Garner, reducing HEM, that sort of thing. And so when you consider sort of the broad market of employer provided healthcare in 2026, that's a projected number. We're projecting a 6.7% increase after they've made plan design changes. And so when an employer, a commercial employer plan sponsor is making plan design changes, they're often a little bit more disruptive than the nature of plan design changes that PEB is exploring. And so think just on a basic level, increasing deductibles, out-of-pocket maximums, co-pays. There's a place for PEB to do that from time to time as well, but it's your typical smaller employer that has less leverage in the market, less leverage with their carriers, is more likely to sort of check some of those boxes. And so this blue line here speaks to the total cost. So think about it as like total premium, but it doesn't speak to the plan richness. And so when they're increasing the deductible, the plan richness is going down. That's more out-of-pocket cost for the employee on that plan, on that employer plan. And so this is sort of a total cost view, but it doesn't speak to member out-of-pocket. If that makes sense. So I don't know, Dawn, if I quite answered your question. So please, if you want to clarify, we can talk about it some more.
No, the way that I asked the question was a little unclear because that was my level of understanding, and I understand better now what I'm looking at there in terms of health benefit cost there on the blue line and what that reflects.
Yeah.
So thank you for the clarification, Andrew.
Okay, great. Alrighty, I think we can move forward and start to talk about 2027. And so, as I mentioned at the outset, we are going to have these related but parallel efforts for the renewals for non-medical and pharmacy, for the RFP for medical and pharmacy. And these have the same effective date, right? We're talking about a 1/1/27 renewal. It's also 1/1/27 effective date for the apparently successful proposers. So those bidders who win PEB's business out of the RFP, that will also have 1/1/27 effective date. And so starting in February, we'll start to take a really close look at dental and vision and possibly the supplemental programs. And then in March, we'll have a similar sort of deep dive into life and disability. And so in those meetings, we are going to be bringing some really detailed benchmarking to just sort of see what we can uncover. I mean, we do benchmarking every year across all of your benefits, but we're gonna go a little bit deeper and see if there are opportunities to enhance the plan, close gaps, all those things that we want to do. And so this time next month, we'll be doing that with dental and vision, and then we'll follow up with life and disability in March. And so one nuance related to this ongoing RFP and managing renewals for non-medical alongside the RFP is that we need to be able to talk about the composite rate starting like in February. And so Emory is going to have his RBC presentation next month. We're also going to take our first look at the composite rate and see where PEB's costs on a projected basis are coming in relative to 3.4%. That's very much on a preliminary basis, right? Because we're using your incumbent carriers, including your incumbent medical and pharmacy carriers, to project those costs. And so we're going to look at Providence claims and MODA claims and Kaiser claims and other experience and utilization. We're going to project those costs forward to 2027 to provide you all, board members, with that context around where costs are coming in, with the caveat that that is going to change once the ASP, the apparently successful proposer, is named by the PED board, which will be in April. And so we'll talk about that timing stuff a little bit later on in the next steps, but I wanted to bring forward that nuance that we're going to start talking about composite costs in February. Just keep in mind that's going to be based on your incumbent carriers, which could change as of 1/1/27. But to talk about dental and vision, plan enhancements, closing gaps, you kind of need to have that context on where preliminary projected costs are going to come in. And so that's how we're going to approach that and facilitate that discussion starting next month. Does that make sense how I laid that out? Sean, I see you've got your hand up.
Yeah, so I'm just clarifying the process right now. And so that it totally makes sense to me that dental, vision, so on, the normal process, so my question is not about that. So my question is, in the RFP review process, like is part of the proposal already, because this isn't the part that I'm particularly reviewing. So is part of it actually the cost part of the proposal that we already know, or does that happen like when we actually get to the point where we have one or several or what have you selected, then we start talking about money in more detail as far as like actually nailing it down, landing the plane. And at that point, we may need to like revisit if the price point just isn't matching what we need to match, then is there a point at which we go back or something and like reconsider if we just can't land the plane with the particular so that's my question about the process of like how does it actually land the plane when it comes to selecting?
Yeah, Sean, this is Brian Olson. I just I thought I'd jump in because we really need to be really careful about what we put out there and what we talk about regards to the RFP.
Right.
I'll invite Mercer to jump in if I'm incorrect here, but long story short, we will provide and present that financial information in April with
Okay.
the various options to select ASPs.
Okay.
Those recommendations could include certain things that we need to iron out for negotiations, which could include rates, covered benefits, other things we highlight.
Okay.
If the full financial picture based on the potential ASPs create some concerns with the board, we will likely have some talking points prepared going into that board meeting to kind of have a discussion about that. But until we actually work through who's going to be a potential ASP, what their proposals like, there's not a whole lot to say about it. I will say we're having the RFP schedule has us doing finalist interviews, I believe, end of March. So that is when we will then finalize all the scores and where the core team with Mercer and staff will then basically draft the presentations with these sorts of concerns or highlights in them.
Okay. That was the level of detail I need. I don't need anything more than that. So thanks. Appreciate it.
Yeah, good question. Thanks, Brian, for jumping in there. Any other questions at this point? Okay, I'm being told I have 10 minutes left, and so some of these slides I might cruise through a little bit more quickly, although we've only got a handful more, so I think we're going to be okay. So I think we can, Rose, if you wouldn't mind, I think we can jump ahead. This is one that I know board members, you've all seen before. It is I think, hopefully you agree, it's sort of a handy framework in terms of translating PEB's values into actions that we can take in this renewal. And so this is really intended to be a decision framework, looking at those questions on the right and applying them to any potential program, plan design changes that we're going to review together. Again, being able to apply these questions to dental and to vision, to your basic life program in a way that we haven't done in the last year or two. Not going to read through them. I think we can probably safe to jump to the next slide, if that's all right. This is just a quick refresher on the role that the Strategies on Evidence and Outcomes Work Group plays as it relates to PEB renewals, and so COW for short. And so Emery talked about this a little bit. The COW work group has identified cardiovascular as a condition of interest to really look at from a clinical perspective and understand how support can be enhanced for those members. This is a high cost category for PEB. It's also a high frequency category. There's lots of members who get services in this category. And so I think that Glenn Bailey is going to give an update on COW and the particulars related to that. And so I will pause there for now. But the other way that COW supports PEB's renewal is through the COW Summer Research Group, SSRG for short. And so dental access is the topic that COW has decided to study in more depth in SSRG starting in May or June of 2026. And so this has been an ongoing topic of interest, and so Glenn will have a little bit more to say about that as well when he provides the COW update. Although not listed here, Emery also mentioned the HbA1c ongoing analysis that started last summer and continues through today and into the foreseeable future to understand optimal medication protocols for members with type 2 diabetes. And so we want to jump to the next slide. This is also an SSRG. It's kind of a good segue since I brought up the HbA1c piece. Just again, this is sort of a reminder on how it fits in. When we get closer to May and June, there might be a request to see if any board members want to participate in that SSRG. But this has been a really successful collaboration between PEB and OEB starting in 2023. So this is just a historical view, but the intent here with the summer research groups is to really choose a topic that has a little bit more complexity and nuance in it, and a topic that really could benefit from collaboration across board, PEB staff, Mercer, and carriers, and really try to solve something that's not easily solved. And so you can see some of our successes, which we've noted here. We've studied weight management drugs, doula coverage, traditional health workers. Last summer was the type 2 diabetes analysis, which is ongoing. And so again, this is just sort of a refresher and a little bit of a teaser that this will also play a part in the upcoming renewal effort. We're going to jump to the next slide, please, Rose. This one talks about how the health equity work group also supports the PEB renewal. And so again, just sort of getting you oriented so that you know what to expect in the next few months. And so when COW identifies a particular renewal change, and again, COW is looking at clinical effectiveness of different services and that sort of thing. When they identify something that has equity considerations, they will bring in the health equity work group, who will complete analysis and lead discussions within COW on their findings. PEB board members who participate in COW will ultimately make recommendations, which will then float to you all, to the broader board. And so this is, again, just to refresh you on some of this work that's happening outside of these monthly PEB broader board meetings. But analysis and findings will be brought to you to, again, make sure you're informed before you're voting on any final decisions for 2027. Apologize, I know I'm going a little bit fast. I think I've got 5 minutes left. I'm gonna rely on folks to raise their hand. I'm keeping an eye on it, so please just stop me if I'm saying something that needs to be clarified. This is a really busy slide. I'm not going to read it. This is just to give you a sense for some of the categories of questions that we pose to the carriers through the renewal process. We work with PEB staff as well as Mercer clinicians. We develop these really detailed renewal letters before sending them to the carriers, and this just to give you a little bit of a flavor for some of the categories of things that we pose to them. This is largely based on PEB's values as a starting point, what we understand to be important to you all, as well as anything that might just sort of be going on in the market that we're aware of. Things are changing all the time. And so some of that can also inform questions that we pose to your carriers. And so the source of questions can vary a little bit, but you look here at just sort of the bolded headers is probably a good way to look at this and not try to read through the bullets at this time. You can kind of get a little bit of a sense for some of the things that we pose to the carriers. And as you all know, this is an iterative process, right? And so we'll post questions again at the end of this month, which the carriers will respond to. We have discussion with the board. You all post questions then. We include them in subsequent rounds of the renewal letters, and we have this iterative process. And so this is sort of the out of the gate round one content that we included in the renewal letters. So I think we can move forward to slide 15, please, Rose. I'm going to show you the timeline in two ways. This is the maybe slightly more detailed timeline that shows some activities happening in sort of key venues that support the renewal here from January through June. And so when we meet next month, we will be reviewing the round one renewal responses from the dental, vision, and supplemental carriers. After we meet with you, we then send subsequent questions to the carriers, and we engage in that iterative process that I described. CIAO will be meeting in early February. They will be doing their initial review of any clinical considerations related to the renewal responses. In March, the Health Equity Work Group will be meeting. They'll have their quarterly meeting. But they will be engaged in renewal support before March, but that's the next time they're having their quarterly meeting. And so we're trying to sort of give you a picture of all of the, maybe not all the things, but some of the key things that happen as we keep you all informed so you can make decisions related to the renewal. And so in March is where we will start to look at life and disability, as well as round two responses for dental and vision. In April, we will have our round three responses from the renewal carriers, or round two for life and disability. And then April 29th is the tentatively scheduled date related to the medical and pharmacy RFP. And so in May, related to renewals, we will approve final decision, ask you all to make your final decisions, assuming that you're feeling prepared by then, and approve final rates for 2027. Starting in May, June is when some of the dental access piece will kick off related to that SSRG done through CIAO. In June, there's a number of activities that Mercer and staff work on to make sure that collectively we're on the same page with the carriers, what was agreed to, we document it. And then starting in June, we will have implementation updates related to the medical and pharmacy RFP. We're going to jump to the next slide. I'll show you this perspective on next steps, and then I'll pause for questions. Actually, I think I've kind of covered everything on this slide. I was going to call out that, the standard will be delayed by 1 month relative to dental and vision. So we'll stagger it. We'll do dental and vision. We'll do life and disability. And I think I'd already talked about the fact that we're going to start including preliminary cost projections in February for those reasons that we talked about earlier on in the presentation. So that's our last slide. And so I will pause and see what questions or comments board members you have.
Emily.
Yeah, wow. This is a lot. I agree with Representative Nose and just appreciate Mercer's team, you all, and like succinctly communicating such complex and deep and wide work. And so proud to be part of this PEB board and all the former PEB board members who laid the foundation, such an amazing, national leadership foundation for this work. I'm always wanting to respond and have so many questions, but I know our time's limited. And one of the comments I want to make is probably outside of the scope of today's meeting, but I'm curious as to when I could dialogue with somebody about it. But in response to Sean's comment about what we talked about at our retreat and just, I don't know, the limitations of drugs as a whole and in terms of improving people's health and wellness. I mean, absolutely, yes, drugs can help. As Sarah Drake always, educates and teaches us, and we know from lived experience. But there's such a big group of people who don't benefit from that. And, I just think about alternative health and healing. I come from a line of traditional Chinese doctors on my dad's side and, traditional in Taiwan pharmacists on my mother's side. And I just think about like right now is the turning point, the 60-year turning point in traditional Chinese medicine right now. And, there's a Taiwanese, I don't know, you wouldn't call him a physician, but he's a traditional Chinese medicine educator. And he has passed away, but he predicted this year, like clockwork, and he predicted this last couple weeks. This is a fire year, according to traditional Chinese medicine. This is one of the hardest 2 weeks of this fire year. And so, he's actually recorded he's done lectures and recorded them and taught students. He's since passed away, and he's also written 8 books. They are starting to be translated into English for the first time. But Asia's already been embracing all of this knowledge. It was never available in English. So my mother has been watching in Chinese and taking notes and then sharing with our family. And so there's like, for example, each day he actually says what to do each day of this week to protect yourself and your family's health. And it has a lot to do with colors. And like I'm wearing the 3 colors that he says that you need to wear he said it's almost like, and I'm still learning about traditional Chinese medicine, but it's like tuning a string instrument. So traditional Chinese medicine is like living in yin yang balance, and it's also about living in one with nature, which Oregonians are great at. And so it fits so well with our environment in Oregon, I'll say. I can't speak for other environments and other communities, but he says when you pay attention to the colors, you're activating yourself, like your thinking and also your environment, your immediate environment. And it's almost like when a musician tunes up their violin before they play, that's what this colors thing can do. So, red needs to be the dominant color that you wear today. And it has a lot to do with your heart and just the way you think. And then yellow, has certain properties. And then green has a lot of
Excuse me.
properties. So anyway,
Emily,
yeah,
sorry, if I may. There's certainly opportunity to engage in some more dialogue about this. I appreciate the richness of it.
yeah, thank you. And, Asian Americans being the fastest growing in Oregon, it's just really, I think, relevant culturally and linguistically and from a health equity perspective. So thank you. I know the time is is limited.
Well, I'll reach out to you offline and we'll
Mhm.
we'll figure out
Mhm.
what it is that's needed to get the dialogue in place, okay?
Okay.
Sean, I see you have your hand up.
Yeah, I was just gonna say that at some point that would be a good, useful conversation. I mean, a lot of traditional medicines, Chinese, Ayurvedic, some of which are covered by national health cares in other countries, have a lot of an emphasis on preventive care, basically, is what we're saying. And a lot of that preventive care is quite aligned with Western understandings of health. It's like moderate exercise every day, all this sort of what are you eating? Are you eating processed food? That kind of thing. Um, all of which is pretty compatible with our understanding of currently what's making Westerners sick, whereas our system is much more orientated toward like what's broke, as opposed to how do we stay healthy. So it feels like a worthwhile conversation at some point, in the frame of like, what does a well care system look like, So yeah, maybe y'all could talk about it and then like we can maybe when we have a minute to breathe as a board, we can, talk about what that looks like. That would be great. Thanks.
Thanks, Sean. There's so many East-West models in hospitals and Canada and Hawaii and clinics and federally qualified health centers as well. So thanks.
Thanks, Sean. All right. Are there other thoughts? I think actually we'll go ahead and close it here. Thank you so very much, Andrew and board members, for engaging thoughtfully here. Let's go ahead and transition to our next speaker. I think it's Ruby Castañeda to talk about the RFP. Have I got that right? Ruby, are you on?
Yes, I am here. Thank you, Dawn. Yeah, so this will be pretty quick, and I'm hoping it'll won't. I'm hoping it'll catch us up a little bit. So real quick, in terms of the RFP, where we're currently at, well, first of all, I would like to thank all the board members, Mercer staff, and PEB staff that are currently in the evaluation process and scoring process. I appreciate your time and commitment for ensuring that this continues to move up or progress along. In terms of where we're currently at, we are in the evaluation stage, and by end of business day, we would like and appreciate all of scoring worksheets to be completed by close of business day today. If you have not sent those in, if you could please send those in, that would be greatly appreciated. Or if you're unable to meet today's deadline, if you could let us know as quickly as possible. Once we receive the worksheets, we will be reviewing them for completeness and ensuring that all scores have been completed and every question has a score. And then after that, we will go ahead and move on to the next stage of the finalist interview and what that's going to look like. We will need to get some board direction in terms of that. And then there'll be the selection process, which will be conducted in April. So we are at the tail end of this huge project, and I want to thank everybody that has made the time and commitment in making sure that this was a priority in everybody's workload. And that's all what I really have, unless there's any other questions. Thank you, and I caught us up.
Thanks, Ruby. Unless there are any questions there, and seeing none, Glenn, I'll go ahead and hand it over to you for the CIO update. Andrew already spoke to it a bit, but please.
Yes, thank you, Dawn. And as you said, yeah, Andrew gave a lot of information on some of the projects that we're working on. So I'll try and be as brief as possible here. One of the projects that we are currently working on, as Andrew talked about, is we are looking at cardiovascular conditions. Specifically, what we're really, we worked with Mercer to develop a set of questions to provide to the OEB medical providers during the upcoming renewal, and then to the PEB ASPs during the RFP that asked kind of got more information on their types of interventions, from early detecting to monitoring their outcomes, and to use these set of questions to then come up with clinical recommendations that would be part of the renewal for OEB. And as I mentioned, it would be part of the for the PEB ASPs in their contract negotiations. I'm happy to go over any of the questions or, any more information, but a lot of that was kind of already provided by Andrew. The next area that CIO is working on is we are updating the performance guarantees for the behavioral health network access standards. These were developed in 2024 by the Innovation Work Group, so that we could get a better idea on access to providers beyond just, the number of providers in a certain area or even just the time to distance, but really looking at appointment wait time, appointment availability. It was even required that as part of this, the carriers would go to an outside firm to do what's called a secret shopper analysis, which is basically where they will kind of pose as members and then get information instead of just kind of requesting it from the medical providers or the behavioral network groups that they're contracting with. This was originally done on a basis of, just a report only. We got the information based on the report only, looked at it in this CIO in the fall, and now what was provided was recommended goals and fees at risk. Right now, there's 5% of the total fees, medical fees at risk, that are available for the behavioral net access standards. Those would be used, and then they would be based on dividing up among the questions, and then based on how they would perform on the goals. This was made part of the OEB renewal, and the final decisions after negotiations with the carriers would be brought back to the OEB board as part of the renewal. And then the same with the PEB board, it would be, as I mentioned earlier, be part of the ASP negotiations for contracting. Are there any questions? I mean, again, I'm happy to provide more detailed information to folks on these. One of the things that also was touched on by Andrew is the 2025 CIO Summer Research Group looked at really kind of improving the effectiveness and the value of type 2 diabetes treatment by developing a reporting framework that could be used to both analyze the utilization of these treatments, but more importantly, what was the outcome? How did they improve the hemoglobin 1AC? And this was based on really looking at different drug combinations, because that tends to be, an area that is used frequently by providers. This was developed by Mercer and with the carriers, and then the carriers reported on this framework for 2 assessment periods. This was brought to CIAO in November. We then did the final review in December, and it did indicate differences between certain regimens and even the outcomes of certain regimens, but further research is recommended to really get at, what are the really final, it's kind of, as they said, an ongoing project that CIAO will be working on. And then just lastly, as was pointed out, for the 2026 CIAO Summer Work Research Group, we will be looking at dental access to really develop develop a set of probably performance guarantees or measures to use for dental access, so that we can better monitor the access and identify areas of improvement, as well as possibly some other ways that better monitoring and the dental access can be improved. This would be starting in May and June, and we would be reporting to CIAO in the fall, and then to the boards in probably the winter of 2026-27. And we will be putting out a call for, we'll have 2 OEB board members and 2 PEB board members. So if you're interested, you can certainly reach out to me, and, we could put you on as one of the members who works on the CIAO Summer Research Group. The research group will include staff, as well as Mercer representatives and carrier representatives. We haven't determined the specific schedule. They tend to run based on the past ones, 1 to 2 times a month or once a month. So it will be that summer when most of the work is done. Again, I'm happy to share any more detailed or provide any more detailed information. Sean, you had a question.
Well, I was just going to add to emphasize Andrew's point earlier. These work groups of various flavors are one of the more powerful tools we've got over time in order to contain costs and improve benefits. I mean, not every employer can do this sort of thing. So, and then put it into use pretty much right away whenever things are discovered. So I just appreciate the updates, Glenn, and just kind of want to be sure all the board members know that it's pretty special, this amount of research power that we've got, and the ability to like implement right into policy is pretty amazing. So just for what it's worth.
Oh, thank you. Thank you very much. That was a really good overview of the benefit of these work groups, because we can really dig into the details and, work through the problems and come up with really effective answers based on the work, that's done through these different groups.
Thanks for articulating that, Sean. I agree. It's special and powerful, and really can inform good policy right away. Thanks, Glenn. Any questions? Anything else for Glenn? Hearing none, we'll express our gratitude to Glenn. Thank you, and hand it over to Margaret Smithisa.
Yeah, thanks so much, Chair. Before I get started, I'm just going to go ahead and put a link in the chat to the most recent innovation workgroup meeting materials. There's a lot of data, so that link is there in case anyone would like to scroll through while I give a sort of high-level update. Just as a reminder, Your PEB representatives on the Innovation Work Group are Kimberly Hendricks, Sean Parkman, and Greg Clauser. Of course, the work group meetings are open to any and all board members who wish to attend. At present, we have the work group on an every other month meeting schedule. So they met at the very first week of December. We nudged that meeting a bit due to the November holidays. So they met early December, and the next meeting is next week. So they'll have a late January meeting as well. In terms of the most recent meeting, December 3rd, the work group reviewed annual level of payment benchmarking data. And this is annual data we look at comparing OEB and PEB 2024 payments across all the various categories of healthcare services, compare those to the level of payment that Medicare provides for those services. I think the overall sort of takeaway is that we are so to speak, losing ground relative to Medicare. So Medicare pays at a certain level. We look at our comparison as a percentage of that, and that percentage relative to Medicare is increasing across just about all categories. So looking at overall, to all healthcare services, the overall level of payment for all carriers for Kaiser is running in 2024 at about 201% of Medicare. If you include the Kaiser's integrated care management fees, which are the additional care coordination fees they charge, it's closer to 229% of Medicare in 24. And that is an increase. Back in 22, they were at 179%. For MODA, 24 is running at 178% of Medicare, 169% 2 years ago. So again, increasing. And for Providence, it's running at about 191% of Medicare, which is about 6 percentage points higher than it was in 22 when it was 185%. So that's kind of the overall picture. There are definitely some areas where payments exceed 200% of Medicare. And again, these are areas that are not capped under Senate Bill 1067. So if you happen to scroll through the slide deck, you'll notice some areas, outpatient services at exempt hospitals are running in the range of 260 to 300%. In terms of professional services, primary care, our payments are running at about 200 to 230% of Medicare. Specialty, about 200%. Those surgical specialties are running higher, 225 to 250%. Maternities in the range of 250 to 285%. Anesthesia and ambulance, which we have always identified as outliers when we look at this data. Anesthesia is running over 300% of Medicare payment levels, and ambulance is in the neighborhood of 400%. So again, all increasing compared to prior, many showing double-digit percentage point increases. One area we're paying attention to is behavioral health. When you look at the physician and office side of behavioral health, that is in the neighborhood of about 125% of Medicare. We're continuing to monitor that to look for more recent data. One of the things that the work group does have on our radar looking ahead relates to legislation that was passed in the state of Washington last session, where they set a floor of 150% reimbursement for behavioral health. That'll take effect in 2027. And I think one of the things we are taking into consideration is what access impacts might happen in areas, particularly along the border, if you've got just big differences in what the payment level looks like, say on one side of the Columbia River versus the other. So that is definitely something that the work group is paying attention to. I will note some areas, when you look more at like commodities, like durable medical equipment, we are pretty much at parity with Medicare. So paying right around 100% of Medicare for those services. The second topic the work group looked at the December 3rd meeting was kind of a more conceptual analysis, looking at approaches PEB and OEB might consider related to leveraging purchasing power and managing quality while also slowing the rate of cost growth. We looked at some examples from other states, from other state employee plans, particularly Minnesota, which has a tiered provider network plan design. The network providers in that plan design are tiered based on their cost and quality, and there are plan design incentives built in for members to seek care from higher tier providers. Also, the Colorado State Employee Plan, which has implemented a tool to help members identify what they call fair price providers. And it basically involves employees receiving sort of a cash incentive when they seek care from those fair price providers. So has some similarities to the new arrangement PEBB has implemented with Garner, although it has some kind of its own flavor, some differences as well. And then also some examples from Tennessee Medicaid looking at their episodes of care payment approach. Long term, I think, really the work group's goal is to be identifying sort of strategic policy approaches that we can look at across OEB and PEBB to further the goals of ensuring robust, high quality, comprehensive plans, while also managing that rate of cost growth. So looking ahead to next week's meeting, which is next Wednesday afternoon, the 28th at 1:30. On the agenda, we're going to have all three OEB and PEBB carriers provide presentation on recent cost trends and payment levels relative to Medicare. The work group in reviewing the data last month had some very specific questions kind of related to some of the information showing up in the data, and we wanted to ensure that carriers had the opportunity to come present directly and respond to some of those specific questions. So that will be on the agenda for next week. In addition, on next week's agenda, the work group is going to be reviewing sort of a deep data dive into hospital cost and utilization, both at capped 1067 hospitals as well as the uncapped exempt hospitals. So again, happy to kind of take any questions or anything. If Sean, Kimberly, or Greg want to chime in with any observations they have, certainly feel free, and welcome all board members to listen in on next Wednesday afternoon's meeting if you're able to.
Thank you. I'm so glad to hear that you all are looking at the hospital cost and utilization. There's an interesting trend there that we have seen some decreases in inpatient utilization. Does that mean we have moved some like inpatient surgeries to outpatient environments? It's less expensive, still high quality. I'll be interested to hear what you have out of that. Sorry, work group members, I jumped in there enthusiastically. Want to jump in? No, anybody else? Board members, questions for Margaret? Yeah, please, Sean.
I'll just say, yeah, those cost increases above Medicare, we had many questions. So we'll continue to drill in on those. That's disheartening, and yeah, we'll keep digging, see what we find.
Thank you. Those are questions that I had emerging from today's conversation as well, the review of today's slides. Ali.
Yeah, I just wanted to emphasize, what was talked about with CL earlier in the innovation work group here, and just the value that they provide. I think, with CL, that was really originated when the OEB board originated and was such a tremendous value to OEB as school districts individually used to procure their own benefits, usually through brokers, had nothing like that, they could take, really important decisions around like evidence-based decisions, and to have OEB kind of create that process and the value it delivered over the years, and then now have PEBB being part of that is such a tremendous value, I think, to both boards, and just happy to hear that articulated here. And then with IWG, we have the governor's office is really interested in getting involved in the IWG's work over the next few months, and really seeing that through as harbinger of, potential savings and efficiencies that we can implement, not just in PEP, but in OWEB as well. So I just wanted to mention that. Thanks.
Thanks, Ali. It's true. All the creative approaches that we can find to continue to improve care, access, and health while at least beginning to contain costs. That's a broader question than just for public employees who happen to be on our plan. Okay. Seeing nothing else on that, let's thank you, Margaret. That's good work, and responds again to a lot of the things that emerge for us as we hear and see the broader overviews, wanting to interrogate that data and see what else it can teach us about specific ways that we might be able to respond to it, that would meet that triple aim, or quadruple or quintuple if you include health equity and provider wellness with cost and quality and experience of care. Okay. On to the next segment of the agenda. Thank you, Margaret. We have a health equity work group update. Sharna Frian, are you with us?
I am. Thank you, Chair. Hi, everyone. My name is Sharna Frian. She, her, hers pronouns. Wearing a green sweater, white aging woman with multicolored glasses and some brown hair with ear cans on. So the Health Equity Work Group met on 12/15 for our last quarterly meeting of last year. And the main focus of that meeting was reviewing the feedback and the suggested items from the OWEB and PEB retreats. Well, OWEB retreat, PEB board meeting that was in person. Based on that feedback from staff and board members, the next steps are to organize the tactics into separate multi-year strategies to prioritize our initiatives. So in other words, we're creating the roadmap and we're putting there's a structure there, and now we're putting the details into the structure. So we expect to work through the first quarter and beyond on those tactics. We're also very excited to, Representative Nose?
No, just saying goodbye. I gotta get to my next thing. I really do appreciate when I can pop into these meetings because it helps me understand what health plans in our state are dealing with and the impact of the laws and budgets I pass. So I'm glad. I'm also, again, as I say every time, I'm really glad I'm not in the procurement process. Good luck.
Thanks, Rep Nose.
See you all soon.
I appreciate him being here. It really feels supportive to have him in the meeting. Okay, so my next item is that we are excited to announce that OWEB board member Dr. Andrea Lara has joined Health Equity Work Group, and we will be meeting with her soon in February to bring her up to speed and kind of give her an orientation about the details about how that work group works. And you also saw, thank you to Andrew, he covered so much of my stuff for me, so this is gonna be real brief. Yes, we are reviewing some of the questions from the renewal letters, and also the health equity questions in the RFP are being reviewed by staff and Mercer staff. So that lens is being applied to those two bodies of work. And we will continue to be involved in that in coming rounds of the renewal. So that is pretty much all I have. Going to be super brief and just wait for questions.
Thank you, Sharna, and thank you to the Health Equity Work Group for helping us stay true to the goal of the strategic goal, even as it even as it comes under a great deal of pressure. Any questions or comments for Sharna or the Health Equity Work Group? Hearing none, I'm glad to hear that Dr. Andrea Lara is joining that group. She is a very thoughtful colleague. All right, thank you, Sharna. That brings us to the last item on our agenda, other business and public comment. Board members, there are some public comments that were shared with you. Please be sure to read them if you haven't already. They are referring to topics that were discussed pretty front and center in today's conversation. I do want to express my gratitude for these members for reaching out to the board with your concerns. Only when we hear from you are we able to understand what your concerns are. So I do appreciate that and encourage it for members of the public employees group. And staff will be following up about that, about your comments. And with that, I'd like to open the floor to the board. Anything else for the good of the order? Or to staff? Mercer? Hearing none. A happy new year to all of you. I was not here at the beginning of the meeting, and I appreciate this collaboration and the work that we do to support and demonstrate the value of public employees and the service that is provided to our state. Thank you to the staff and to Mercer, and we'll look forward to seeing you next time. This meeting is adjourned. Have a good day.
Thanks, everyone.
Thank you. Happy New Year.